thought those were just incredibly exciting talks, and all of them are, interestingly enough, about things that are extremely common. So we're talking about diseases that everyone has, or periodontitis, which almost everybody will have at some point, and EBV, which almost everybody has, and certainly everybody has a microbiome that develops in one way or another. And I think that presents some real interesting and complicated thoughts about how you're going to address these later on down the line. I'd like to open up this to your questions. We have a few, I think about 10 or 15 minutes, and love to hear what people, go ahead.
A question for Dr. Lynch. It appears, of course, that the whole process of amyloid formation and tau tangles is generally a protective mechanism that seems to have evolved against multiple microbial threats. Not necessarily specific, of course, to P. gingivalis, because it could be other bacteria as well, but also viruses. It appears that herpes virus, again, has been implicated, and there have been studies from different parts, including Taiwan, saying that people treated for herpes virus are better protected as opposed to those exposed to herpes virus but not treated. So this whole thing is an evolutionary protective mechanism?
I think the A-beta certainly is. Antimicrobial peptide response is not specific to a specific pathogen, and yes, it's been shown for other pathogens. I think the constellation of data around P. gingivalis personally, obviously, that's why I'm here, and bringing a drug to the clinic is extremely compelling and really checks all of the causation boxes. I think there is more work to do around other pathogens, and it's important to test those hypotheses in humans. Let's do a big study of acyclovir and see if it's, let's get it out of basic research if you believe it. And that's what we've really tried to do is press this forward into human clinical studies to make a difference for patients.
Go ahead.
Great talks. Two questions. As a follow-up, so with the notion that the Alzheimer's is related to intracellular infections by the P. gingivalis, couldn't you just use antibiotics? And
Right.
I mean, I realize there's the blood-brain barrier issue and all that kind of business. Has that been looked at?
Yeah, so we did a lot of head-to-head testing, and I skipped over this, but it's well studied in the dental field. You cannot eradicate P. gingivalis with broad-spectrum antibiotics. It's both persistent and oftentimes antibiotic resistant. It's inside biofilms, it's inside cells, it's gram-negative. So it's a chronic recurring infection in that area, and so that's why we developed these virulence factor inhibitors, which do work, number one, to block the toxicity of these gingipains. And I should mention, even though the A-beta response we don't think is specific to P. gingivalis, we do think the constellation of pathology that's produced is really tied to P. gingivalis and the activity of these gingipains, the fragmentation of proteins like ApoE and other important intracellular proteins in neurons. We think that is a gingipain-dependent effect. So when we block that, we, number one, make the bacteria completely benign, and number two, you starve off the P. gingivalis bacteria. So it's a new type of approach to infection, and it really has a lot of benefits as far as adverse events and antibiotic resistance.
Great.
We haven't seen
Okay,
it yet.
thanks. And Dr. Nagler, this issue with the microbiome, and for instance, these butyrate producing bacteria, do you think that you could just, do you think you can repopulate the gut, and that would be the easiest thing to do? Or do you think this is now a chronic situation where these organisms would not survive, or the new microbiome is just always going to be different and you're never going to be able to repopulate?
So the short answer is no. I think repopulation is really difficult. There are many, many startup companies that are focusing on live biotherapeutics with the intention of repopulating, particularly in C. difficile colitis. That's been the first outing for this. The problem is when somebody has, like a food allergic patient, that has a dysbiotic but complete microbiota, there's no niche to introduce new bacteria into. So that's why we've taken the microbial metabolite approach. But one interesting thing we found in our first testing of our drug is that it actually induces in the small intestine antimicrobial peptides. So we think it has a microbiome modulating capability, and that if we give it, start to modulate the microbiome, give in fiber, then give perhaps some live biotherapeutic, we may start to create a foothold that would allow it to populate to a certain extent. And that's our goal.
Great, thanks.
Great. Thank you for this great talks. I'm Jay Varma with CDC. One question for Dr. Nagler, just to follow up on. It's not working, I guess. Or just push, right? Okay. Hello. Oh yeah. So one question, follow up for that was, are these sort of gut peacekeepers that you refer to, are they exclusively acquired in the birth canal during birth, or do we suspect that they were acquired at some other time during infancy? So that was the question for you. And then a question for Dr. Lynch was about, and I may have missed it in the talk, but is there an epidemiologic association between populations with different levels of dental hygiene and the occurrence of Alzheimer's? Or is it, as you mentioned, it's so persistently difficult to eradicate that it may not even correlate to dental caries or other issues?
Yeah, exactly. I mean, I think there's a couple issues. If you're looking at different countries, they all have different diagnosis rates, different mortality rates. So trying to do that kind of analysis it's not going to pan out, especially because there's so many different factors between having periodontal disease and Alzheimer's. We are not saying periodontal disease causes Alzheimer's. You may never have periodontals, no symptoms, and you can still get Alzheimer's disease. It's the same infection in two different organs. So, I mean, there are some indicators if you just look within the U.S. at, for example, African Americans have the highest rate of periodontal disease and of Alzheimer's, followed by Hispanics, followed by Caucasians. So you can do some things like that, but I think the population level analysis is complicated by multiple factors.
So I lost my intro slides in the 10-minute presentation, but and I neglected to mention that the Clostridia are obligate anaerobes. They're highly oxygen sensitive. They're predominantly spore formers. They're acquired from the environment. There is an association with mode of birth and susceptibility to disease, with more disease in children that are born by cesarean section. But the bacteria that are acquired at birth, critically, in nature's strategy, are lactobacilli from the mother's vaginal tract. Babies that are born by C-section actually have as their founder bacteria skin-derived bacteria. How long that founder effect impacts them is still controversial.
So I'm going to take the opportunity to ask a question because I just want to bring this back to some things that we talked about in the first session today. And some of these diseases we more commonly think, they happen all over the world, but we more commonly think of these as first world problems and things that we see a lot in high income countries. And I'm wondering if there are things, when you look at the patterns of these diseases, that you think we should be learning about in countries which have not yet had epidemics of food allergy and have not yet reached having just huge amounts of Alzheimer's disease or lupus, and whether we should, what we should be learning to prevent these things from happening down the line.
So it's been clear in the last, say, 10 or 15 years that China and Japan are somewhat behind us and are now catching up with us rapidly. And all of those lifestyle factors that I pointed out, particularly the use of antimicrobials and antimicrobial hand soaps, and diet. Those are the two big drivers. But there's also an added problem in the US about the age of introduction of allergenic foods that help to drive the increase here, which may not be impacting other populations.
For the example of multiple sclerosis, it looks like the age of infection might make a difference, basically because if you have if you get a serious EBV infection during teenage years, that increases your risk of multiple sclerosis between 2 and 7 times. And so the primitive, all of our ancestors were catching this virus in the first few years of life, and that looks like it's more of a T cell response. And this humoral response that seems to mediate some of the teenage years is happening later in life. And so I think we're kind of built to have a infantile response to the virus instead of one that's later, and we might avoid some of those issues if we were all infected earlier.
Yeah, so I always emphasize that we don't know, the press tends to run away with this and say, everyone, dental care will prevent Alzheimer's or slow Alzheimer's. And I always back that up because that study has not been done. We don't know if treating periodontal disease will reduce Alzheimer's. And in fact, there was a study done, which hasn't been published yet, but anecdotally, the response was we really couldn't treat the infection and the inflammation well enough to even test that hypothesis. So, and once an infection is established, the treatment itself could cause translocation of the bacteria, et cetera. We don't know whether it's going to be helpful to reduce that load in the mouth or actually start moving it around the body. But I guess I do think probably preventive oral care, good oral health care from childhood is a good idea at preventing ever getting a high load in the mouth. At least epidemiology supports the idea that prevention, that is one of the risk factors for Alzheimer's would be to have a high load in your mouth. So preventing that from happening in the first place would be a good idea.
So Casey, could I ask a question? Sure. Have you tested your drug for periodontal disease? It would seem that that would be the easiest phenotype to work with, especially since you're tackling the major organism.
Yeah, so we have in both the mouse model and a naturally occurring dog model, and we do have efficacy in periodontal disease, and we're doing a sub-study in the Alzheimer's study for efficacy in periodontal endpoints.
Can you get FDA approval for periodontal disease?
Absolutely. It's a chronic recurring disease with an unmet medical need, yes.
And so how do you control for the Alzheimer's patients forgetting to brush their teeth?
I mean, the Alzheimer's patients need a treatment that gets into the brain, so we're not too worried about what's going on in their mouth at that point, although hopefully we'll have benefits there too.
I think we have time for maybe one more question if there's one left in the audience. All right, well, I'd like to thank the speakers very much.